Hello, everyone. Welcome to the webinar two of Forum Circle Menopause and More, brought to you by Forum Health in partnership with the Longevity Lab. The Longevity Lab is the source for credible health advice made actionable, accessible, and affordable to you. And Forum Health is, as you know, our partner and provider of all things health. This webinar is going to be about managing symptoms and daily disruptions. It's the second one in a series of 6 webinars where we are tackling menopause and all of its associated conditions for our women members. Real quick, the providers, as you know, are Dr. Shilpa Saxena, Jocelyn Segal, Tara Bullock, and Arisha Barcoles, who will be the providers behind every answer that you get to your question on the WhatsApp community that we have created. If you're not on the WhatsApp community, please go to the landing page, the link for which I will soon display, and you can join it over there. Our approach, as we know, is functional integrative medicine, where we try to find the why. We go for a natural first approach, and we try to restore balance so that we are able to treat the root cause of every condition and give you the best health outcomes that you can have. And with that, we're here to address any questions that you may have about the program or ongoing community support, or how this might fit into your menopause journey. And to kick things off, I would like to hand this over to Dr. Shilpa Saxena and Jocelyn for us to take this forward. Thank you so much.
Well, welcome back, everybody. I just wanted to give a little recap. At our last webinar, our first session, we learned about the differences between perimenopause and menopause. And we were delighted to get to know some of the personalities. So Dr. Saxena gave a great analogy of our estrogen, our female powerful energy is Barbara Streisand, that represents estradiol. And Thor was our great male power. And we also had Mr. Rogers. He was introduced as our DHEA, more calming male energy. And then our calm mama, progesterone, which to help give us this calming energy. So I think for many of us, I could speak for us all, that it gave us a great visual on how hormones really greatly impact our bodies, and what it takes to go through that period, right? So she gave a great presentation on that. Is there anything, Dr. Saxena, any highlights from our first session that you would like to add on today?
Yeah, thanks, Jocelyn. Well, welcome, everybody. It's always great to be with you. I'm excited to be here with Jocelyn to be able to further this conversation. For those of you who weren't able to attend last time, we really went into the identities of the hormones that Jocelyn just went through. So just as she said, estradiol is active female energy, whereas progesterone is calming female energy. Okay. And that's to say that men and women both have all these hormones. They just have different amounts of them. Okay. So on the female axis, estradiol is activating, progesterone is calming. And then on the male axis, Thor or testosterone is activating, whereas DHEA or Mr. Rogers is calming. So the thing that I want to make sure you get is that we have 2 active hormones, male and female energy. And then we have 2 calming hormones, male and female energy. And our goal is to get those 4 into balance as we are moving through the various stages of our life. And one of the other principles that we discussed, which is going to be repeated here, but let's just make sure we understand this, is that when a woman is going through her entire timeline, she is actually born with a little estrogen from her mother. And she might even have a little newborn, can have a little mini bloody show from literally having a withdrawal period from her mother's estrogen hormones. Then a young child, female child, doesn't have anything really going on hormonally from the ovaries until they turn on, they sputter. Then they get a nice little groove. We call that normal reproductive cycling, where you're having your periods. At the end of that reproductive phase, that's also called premenopausal. Okay, pre is when you are cycling relatively regularly. And then towards the end of our reproductive cycle, around age 45-ish for most women, but it can be earlier for other reasons, genetics or abnormalities, then women start to sputter off. And just like we sputtered on when we started with our periods, we weren't regular from the get-go, most of us, we become irregular, and that is called perimenopause. Peri to me is you're circling the drain, not like it's a bad thing, but just like that's what's happening. And then if you do not have vaginal bleeding for 365 days, and assuming there's nothing in the way, like an IUD or something like that, naturally speaking, no bleeding for 365 days marks this moment called menopause. Medically speaking, menopause is 365 days of no vaginal bleeding. And then after that time, after that milestone of 365 days, you are called post-menopausal. Now, that's how doctors and healthcare professionals speak. But in the lay community, people call anything after the milestone of menopause, which is that 365 days, they don't say post-menopausal. They just kind of call it menopause. You with me?
Mm-hmm.
So lay people kind of use the word menopause as a catch-all for anything after those. Well, some people misuse it to be perimenopause. Okay, but when you are circling the drain, you are not menopausal. You are perimenopausal. You are only menopausal after 365 days of no bleeding. Again, assuming that there's no IUD involved or some sort of blockage or something like that. All right, so those are the basics that we learned from our first webinar that are important to build on as we start talking about, well, how do you manage the stuff that happens when you're circling the drain, or, so meaning perimenopause, or if all the hormones have fizzled and you are formally postmenopausal or in menopause, okay? There's junk that happens to women at that time that can be really disruptive, and we're going to learn how to understand that and how to manage it. All right, so Jocelyn, I'm going to bring it back to you to start that conversation.
Okay, great. So today we are focusing on strategies, right? We're going to get into symptoms related to hormone imbalance, and we're going to delve right into there to explain how every symptom, which hormones that it's related to, and what we can do to improve our how we can manage those symptoms best. So looking at some of your questions that many of our participants have already posted, I see many of you are really concerned. You want to know what estrogen deficiency, and I do want to make a note here. There are 3 types of estrogen in our body. So I do say estrogen, that's just common. It's just been a common practice of mine. I really should be saying estradiol because estradiol is the most abundant hormone in our body. So if I do slip up and I say estrogen, it's more estradiol, and Dr. Saxena will explain that too a little bit. Anyhow, so some of our participants wanted to know how estradiol deficiency affects our cortisol levels, fat, brain fog, right? Insulin sensitivity. And so she's going to explain that relationship to us.
Okay, great. Thank you, Jocelyn. Yeah, we definitely see a lot of questions around not just what we call sex steroid hormones, which are estradiol, progesterone, testosterone, but also other hormones like insulin as a hormone, cortisol as a hormone, thyroid as a hormone. Okay, so this is like a big extended family. Sex steroids are just one nuclear family, but they've got cousins, the thyroid family, and they've got cousins in another family called the adrenals, and the adrenals make cortisol and DHEA, and there's another family in this big family tree, which is the pancreas, and the pancreas releases insulin hormones, okay? So this is the big, I'm an Indian, Jocelyn's Italian, we got these big extended families, and as you know, if you are a part of a large extended family, all the other units of family affect each other. So that's not any different in the body. So our sex steroids are very much affected by insulin, cortisol, and thyroid. So all that to say that they're kind of like in a matrix. And it's not always that it's your estradiol or perimenopause or menopause that's initiating the imbalance. For many women in their 30s, maybe even earlier, they could start having thyroid and insulin issues. And if you lead a life with a lot of chronic stress, cortisol issues. So if you can imagine that the thyroid family or the pancreas family, which is the insulin, or the adrenal family, which is the cortisol, they're all off. Well, that's going to make the sex steroid family, meaning estradiol and progesterone, be a little bit wonky from the get-go. Like when you hit perimenopause, if that other part of the extended family has been off, it's going to throw off our ability to get your estradiol in balance. Okay. So, what would be useful to me, and I'm completely fine with people not showing their video, but just so I know that you guys are tracking with me, feel free to put up a thumbs up like you're tracking, or you could put a thumbs down if you're like, whoa, I do not know what the heck you're saying. Say that again. Okay. And that way I know I can continue. All right. So the first principle is that other hormone families need to be evaluated if you are not feeling optimal with the sex steroid family. Now, what should happen, what would be nice to happen is that, oh, you're pretty good at managing your stress. Okay, that's what makes our adrenal family happy. You're good with managing your blood sugar, okay, which means you're eating healthy, lots of fiber, protein, good fats, not a lot of processed carbs. That's what keeps the pancreas and insulin family stable. And then you've got the thyroid family. A lot of that has to do with genetics or, getting in the right amount of vitamin D or selenium and certain nutrients. But if you're keeping that family happy, well, then I can treat the sex steroid portion of your perimenopause, menopause rather simply, because it's the only family that's out of balance. And what generally happens is that in perimenopause, the ovaries are shutting down or slowing down production of estradiol. And so our goal in helping belly fat, brain fog, insulin issues is really just to provide estradiol in a safe way, which usually if you have a uterus and or breasts, we always want to pair it with progesterone. And that's a simple thing. If you're not getting answers when you just put back estrogen, that means there's something wrong with another family that we need to look at. Or there's one other player. Well, there's always a lot of players, but this is another big main player that can interfere in the extended hormone family harmony. And that is your liver. Your liver is in charge of metabolizing, which means degrading and kind of like bagging up the garbage of all your hormones, specifically estradiol and testosterone. So if your estradiol gets used up during your lifetime, and then it doesn't get bagged up and removed appropriately by the liver and then the colon, this garbage estrogen can back up in your body for decades. Okay. It's not like, oh, I was bad when I was 21 and I drank too much alcohol. That probably hurt my liver. So maybe that I was bad. But, I've been such a good girl for 20 years. So I shouldn't have any liver problems. Unfortunately, there's just things in modern society that can throw that liver back. And therefore, you back up this estrogen. And you can actually have this thing called estrogen dominance. Now, I want you to think about that. Everybody in conventional medicine is taught that the only thing that can happen during menopause is that your estrogen levels are low. So their general answer is to always replace estrogen, right? Like if you always assume that the person's thirsty, you're always going to give water. right? If you're assuming the person's thirsty, meaning low levels of water or low levels of estrogen, then your common solution for everything is give estrogen, give water, they're thirsty. However, what I'm telling you is there is another very common scenario called estrogen dominance. And you can Google search that and learn a lot. That can happen for a variety of reasons, usually related to the liver and or the colon. Chronic constipation will do it. That leads to this thing called estrogen dominance. And you just imagine if someone is flooded with estrogen, do you think they'll get better when you give them more estrogen in the menopause state? No, they would not. Okay, so if you actually feel worse when you're given hormones, it could be a signal that you may have estrogen dominance. And Jocelyn, there was a question that we answered as a group related to testing. That's where testing becomes super useful. Because Jocelyn and I would check your estradiol level. And if it was really high, we wouldn't give you estrogen. We would try to figure out, why is it high in a 59-year-old woman who's postmenopausal? Makes no sense. Then we'd go looking into the thyroid. Well, is the thyroid sluggish and it's not moving the liver along? Is there something fundamentally wrong with the liver? Like, we would go into a root cause analysis of why is the estrogen backed up. So that was a very long answer, but I hopefully gave you some ideas of pearls that are related to the fact that really important to know where you stand with your estrogen levels so that you could either replace if you're low or support the liver and the colon if you're high. And those would then help with belly fat, brain fog, because backing up toxins just as much as you back up estradiol will cause brain fog, and it will cause belly fat. Just because you're 56, 59 doesn't mean that menopause is the cause of your belly fat.
Exactly. So let's talk a little bit about that belly fat, because I think the majority of women, when they reach in menopause at that time, they have typically it's like a 10-pound weight gain. And despite exercise and nutrition, they still can't get the weight off. And I've seen this already. We've seen it on the WhatsApp. Our participants are talking about this. Are there any other ways that we can help them through that to help get that weight off?
So from a functional medicine perspective, I'm going to give you kind of our top, some of the most common reasons I see that women get those weight gains, despite like eating clean, exercising regularly. All right, the first reason is the thing I just mentioned, improper detoxification. A lot of that has to do with women having healthy bowel movements, 1 to 3 toothpaste consistency, spontaneous, like you don't have to push them out, complete, like you're not doing it in sections throughout the day. Toothpaste consistency, if you've ever seen that Squatty Potty commercial, you know what I'm talking about. It's like that soft serve ice cream thing. There's a lot of women who don't do that. And if you don't have healthy bowel movements, your liver can't get rid of garbage. And if you can't get rid of garbage, you cannot lose weight. Well, it makes sense, right? Like if you're trying to clean your house, you need a garbage man. So that's number one. And one of the things that we have in a functional medicine perspective are health coaches who train our patients and clients on how to do a healthy version of a liver detoxification and how to get healthy bowel movements, because that is a common reason why women plateau with weight loss as well, because they just backed up toxins. Number two is a vitamin D deficiency. When women get their vitamin D tested and they see a provider who is not trained in nutrition, they will look at their lab levels, and those lab levels give a range of 30 to 100 typically. Okay. Now, if you do not want rickets, if that is your goal in life, a 30 works. Okay. But for most of us, We want more to life than just not having rickets. As you start getting your vitamin D to a level of 50, you start improving insulin and heart disease and metabolism. When you get up to 60 on your blood level, you start improving your immune system and your hormones and your autoimmunity risks. And this is the funny joke I say. It's not even a joke. It's a true story. I just happened to practice in a part of Florida where there are 3 subdivisions. It's the nudist capital of the world, or at least the US. So I've taken care of a lot of nudists. Now, nudists in Florida, you would think would have very good vitamin D levels, would you not? I thought so. No, many of them were in the 30s. So many women need to take vitamin D3 with K2 in order to get their vitamin D levels up, because vitamin D acts like a hormone. And if that vitamin D is not up, thyroid can't work well, insulin can't work well, and your sex steroids don't work as well. Okay, so number 1 is detox. Number 2 is nutrient deficiencies, most commonly vitamin D. And then number 3, and this is not in any particular order, but just the top 3, is women who think they're not stressed, but they sure are. Okay, I'm gonna call that denial. Now, it's not like you're in full denial, but I think we've become like maladapted to this lifestyle of running around, sandwich generation, trying to be the super performer at work, got to be a super mom. We got to also take care of our parents. It's like a lot. And if you are a stress monkey about it, your adrenal is going to make it very hard for you to lose weight. So that cortisol that the adrenal is going to put out is going to prevent you from losing that 10 pounds and is going to help you gain more, because it thinks you're in danger. And so what it's doing is stimulating fat production because it thinks that you're going to need it so you don't starve to death, because that's the only thing your body thinks you might be in danger of, starving to death, which, most of us aren't. All right. So hope that, Jocelyn, what do you think? Is that pretty?
No, very good. Yeah, very good. And sometimes thyroid too, if there's any issues with thyroid that, if you're in a hypothyroid state, it would be difficult to lose weight. So like Dr. Saxena mentioned, getting the testing done, before, during, when you're on hormones is very important. So important to recognize your symptoms for what they are, what they could be, and, and get them evaluated. I would like to go back a little bit to the sleep disturbances. I know it's very important for women. We noticed this, we mentioned, you talked about that in our first session, how that is the most common yet uncommonly known symptom of early perimenopause. And it was attributed to the low progesterone, right? Because that's the first hormone that we see to be lower in perimenopause. What other things can women do? I know, maybe we could expand a little bit more on the progesterone treatment, and then any other options for them to improve their sleep.
Perfect. Okay. So let's just make sure we understand what a sleep disturbance is. It's any difficulty falling asleep, staying asleep, early morning reawakening to where you can't go back to sleep. Like classic perimenopause, menopause is where you wake up at 3 or 4 o'clock in the morning and you just cannot go back to sleep. Mm-hmm. You are like up for the day. That's early reawakening. And then kind of as a fourth general rule is like you did all the sleeping, like you were in bed for 7 or 8 hours, but you just don't feel restored. Like it's a poor quality. Okay, so that's what I mean by a sleep disturbance. So the first and most common reason women have sleep disturbance in this perimenopausal state, which is kind of like your early to mid 40s, is a sleep disturbance. And I would say the most common is staying asleep and early morning reawakening. Those are the more common ones associated with progesterone declining. Okay. Now, interestingly, we don't have a situation generally called progesterone dominance. For some reason, when our liver is not working as well, or our Colon is not pooping as well. Progesterone doesn't back up. Okay. So we are generally safe in replacing progesterone in perimenopause, menopause. In fact, it's my go-to hormone in the beginning. Without any testing, most of us would feel very confident putting a woman on progesterone. Now, here's a little functional medicine tip. The type of progesterone, notice I'm not saying progestin. Progestin is fake. Think of tin at the end. Is not something you want in you. Okay. Progesterone is natural. So what is available through your routine prescription at like a Walgreens or a CVS through your insurance is what we call immediate release progesterone. Okay, which really helps women who need support falling asleep because it kind of gets dumped on the front end of the night. You take it at bedtime, it drops at the front end of the night. And if you have difficulty falling asleep, you got this big kind of dose of progesterone. It goes into your body, through your guts, into your bloodstream, goes into your brain and tells your brain to relax. But because it's immediate release, you get your full dose on the front end of the night. And if you're somebody who wakes up often or has early morning reawakening, there's no more progesterone left over later in the evening or early morning to put your brain back to sleep. So retail pharmaceutical versions of progesterone are immediate release and only, I shouldn't say only, but generally help people who have issues falling asleep. So don't, if your provider doesn't understand that they can compound progesterone to be a sustained release, it could still be progesterone that's your problem. It's just that you're taking the wrong format of it. And that's where functional and integrative providers are very comfortable doing sustained release compounded progesterone. And then the other thing to note is we have an OBGYN in our practice who does a very unique model. And many of our OBGYNs in our network will tell you that the pharmaceutical options right now are 100 milligram and 200 milligrams of progesterone. Okay. The brand name of it is called Prometrium, if you've ever heard it. But there are women who need 300. There are women who need 400. Every now and then there's a woman who needs 500 or 600. But most women need 200 to 400 milligrams. And if they have issues related to staying asleep or early morning reawakening, they need the sustained release option. So there's still some progesterone crossing over into the brain throughout the night. You with me, guys?
Mm-hmm.
Okay, good. So when we trial progesterone, you got to make sure it's the right dose and the right format before you throw progesterone out the window. And that's what happens is people are like, oh, 100 milligrams progesterone, immediate release didn't work for me. It must not be progesterone. I'm like, nope, that's not true. So the most common reason for sleep disturbance in perimenopausal and menopausal women is low progesterone. And like I said, 200 to 400 milligrams, usually sustained release. I'd say 80% of my women need the sustained release. 20% are okay with the prescription version, 100 to 200 milligrams of immediate. Now, the other two things that will cause a woman's sleep disturbance, like, so let's just say you got the optimal dose of progesterone in you, or you don't need progesterone, let's just say. Then the other two reasons are, number one, low blood sugar. People will women will, especially in an effort to lose weight, kind of starve themselves towards the end of the night, and their blood sugar dips, and their brain's like, no, you better wake up and go get some food, or wake up, and then the blood sugar, the pancreas calls over to the adrenal and the liver like, hey guys, blood sugar's too low. And the liver's like, hey, don't worry, I'll go dump a bunch of my stored sugar down into the blood for you. I got you. Okay. But in the meantime, your body's like, what the heck? Why is the blood sugar so low? It's in fear that your blood sugar is dropping. So it's going to wake you up to go get some food. Okay. So low blood sugar is a common cause. And one of the things that our health coaches help women with is using a continuous glucose monitor. If you've ever seen those people with a little disc on the back of their forearm, I just did a 2-week trial myself just so I can understand what it feels like. It looks like you have some needle jabbed in you for 2 weeks. It does not feel like that at all. It's very easy to insert, and there's over-the-counter versions, and we can always get you connected to our health coaches to learn how to use that to detect if your blood sugar is dipping in the middle of the night, causing you to wake up. So if the one reason is that you're not eating enough. The other reason is you're eating the wrong foods, which are generally like, oh, I think I'll have a little bit of cheesecake before I go to bed. Oh, this crackers with hummus. I'm so healthy. I'm eating these crackers with hummus. And your blood sugar will spike initially from the carb or the dessert, and then it crashes.
Yeah. Eating sugar late at night for me means nightmares.
Oh, yes. Sugar is a drug. It's a literal drug. It's been shown to be more addictive than cocaine, actually. All right. So we said blood sugar issues. Then the third thing is what I call the middle of the night witching hour. Okay. And what that is usually between 1 and 3 a.m. If you wake up between 1 and 3 a.m. pretty regularly, I mean, you can still go back to sleep, but it's almost like clockwork. It's always somewhere between there. That's the adrenal that got too activated during the day from your stressiness. And then it just wakes you back up because it's almost like, hey, don't go to sleep. It's dangerous out there. You told me it was really bad out there all day. So just don't go to sleep too long. And it wakes you back up at 1 to 3. And most of us who have had that will wake up thinking. Any women who can identify with that? Give me a thumbs up. Yep. That's the witching hour. It's a sign that your body is saying, please find me ways to relax because you're stressing me out. So those are the top 3 reasons why women have sleep disturbance in this age group. Okay.
I would like to add, because I was working conventional primary care medicine. So, it's very interesting. We didn't really look at the hormonal. Yes, we knew about the stress that people have in their life, and that was affecting their quality of sleep. But it was always my job to make sure they didn't have sleep apnea. So that is not hormonal related. That is a physiological condition where it's either obstructive coming from up here or central from the brain. So that's just something to look at, because as we are repairing and balancing out your hormone levels, and if we're still having those, especially awakenings at night, it could be sleep apnea. And that could be, and that's setting an impulse, the brain telling your lungs you need to breathe. And then all of a sudden you wake up sometimes gasping, or, or you just wake up, you don't remember, you don't know why. So that's just something else to kind of keep in the back of your mind.
I think that's super important. And, it doesn't hurt to ask your partner, am I kind of snoring, choke, gasp, wake up? And that would be kind of the obstructive, your tongue falling back in your throat pattern. And then central, it doesn't always have to have that big, like, choky sense. It could just be your brain forgets to tell you to breathe.
Exactly.
So thanks for adding that, Jocelyn. I think that's worth mentioning for sure.
There's some comments on here now. Would you like, would that be okay? We can answer those now.
Sure,
it's pertinent. So Namrata just mentioned, I wake up multiple times at night, a couple times go to the bathroom, but I'm able to go to sleep right after. So you're able to go to sleep right after you wake up. I think that's great. And I think that what women will find when they start on progesterone, I had one woman that told me that, for years, 10, 20 years, she would always wake up in the middle of the night because she had to go to the bathroom. And I'm like, well, you think it may be the bladder sending a signal for you to wake up because you have to empty your bladder, but it actually could be that you're waking up for other reasons. And then you realize, oh, whoa, my bladder seems full. I think I'm going to go to the bathroom. That you can go back to sleep after you go to the bathroom. That's great that you have the ability to do that, because many women can't. But you'll find with progesterone, with, like I mentioned, my patient, I started on progesterone, and she was down to 1 awakening at night to go to the bathroom. And she was thrilled with that.
I would agree with you, Jocelyn. I think it's great that you could go back to sleep, but you are interfering with your body to be able to have deep sleep.
Deep sleep. Exactly.
And deep sleep is where your immune system, your brain, all those things need to heal. So if you're waking up, it still is interfering with the loop of
Correct.
deep sleep.
Yeah, because when you wake up, it starts all over. You have to get
all over. You can't
go
get
through the
down into
phases.
deep sleep.
Mhm.
Yeah, and our immune system becomes 40 to 70% smarter and stronger
Mhm.
in that deeper sleep state. So it's not, we're not trying to scare everybody like you're broken, you're broken. It's not to say that you're bad. It's just there's opportunities to optimize.
Good. I'm going to go up here to Vanny. Her vitamin D level range to be, okay, vitamin D level range mentioned was to achieve 50 to 60. How is that achievable? For vitamin D of 30 currently, can this be achieved just by diet? Or is a one-time high-dose medication to jump to that level and then maintain it? Basically, how could she raise her level up to a level of 50 to 60? Can it be done through diet? Or is just a one-time high dose of vitamin D2, which is what we give, would that be the fix-all, and then that's it? You don't have to go to any maintenance D.
Okay, so I always like to look for truths across, and you probably saw that in one of my answers. Do you think that if you put in $1,000 for one day, that's good enough for? Okay, that'll carry me now. I got my financial thing to look good. No, vitamin D behaves the same way. So I think what I'll tell you is from being in Florida, practicing for 25 years, I have not met very many people who can get their vitamin D level up and maintained at a level of 50 to 80 with diet alone. I think that the quality of our foods, the quality of our soil, and listen, I also take care of biohacker athletes. I take care of people who are ridiculously healthy and still by diet alone cannot get their vitamin D level to range. So it's not really, I don't think it's a reflection of the person. I think it's a reflection of our food supply that we're not able to get that. And then you might say, well, vitamin D comes from the sun. Okay, but you see, the precursor comes from the sun, but you still need a healthy operating kidney, liver, and other parts of your body to take that precursor and convert it to the form that your hormones, your heart, your brain needs. So I will tell you from my experience, because I have a lot of people who are purists who want to kind of do everything with food and exercise. It's much harder. What I would say, what I've learned, because I used to be one of those people, and I would try very hard to do everything through diet, exercise. And then I learned, my prediabetes risk is just not budging. And so what I needed to do was supplement with vitamin D. And as a fellow Southeast Asian, we got this thing called melanin. And that means we have to get even more vitamin D than our friends who are more fair-skinned. So this melanin blocks 6 times the precursor. So for women of color, it's even more difficult for us to hit vitamin D through diet, sun exposure, just so you know. And here's the other little pickle. Women of color, especially demographics, like people who are Indo-Pakistani, Asian, South Asian, Latin American, our risks for insulin and thyroid and heart disease, mostly insulin and heart disease, is higher. And vitamin D is one of the reasons, low vitamin D is one of the reasons we suffer from that. So when you get your vitamin D level up, you're also helping another issue that is specific to people of color, many people of color.
Okay. There are a couple of other questions on here, ladies. I'm going to put those on hold because they may be answered later in our session. So we'll come back to those. But anything that you want to ask that's specific to the topic that we're discussing, then we'll go ahead and address that. So let's continue on with our symptomology and how we're going to treat hot flashes and night sweats, because these typically occur at night, which also adds to why we can't sleep. Dr. Saxena, if you can explain about what causes that, which hormone is really responsible for that, and what are some techniques that women can use to help improve them?
Okay, great. So let's just define a hot flash is generally something that makes us feel hot, this kind of vasomotor flushing, this like immediate abrupt onset of feeling hot, sweaty for some women. That's usually a daytime symptom is the way we call it. When it happens at night, we call it a night sweat. So it's kind of the same thing, but if it's happening during the day, we call it a hot flash. If it's happening at night, we call it a night sweat. Now, here's the little kicker. Hot flashes and night sweats are very common in perimenopause and menopause. Most everybody assumes it's from low estrogen. And you will not be surprised to hear from me that it can also be caused from high estrogen. Okay, so if you have too little estradiol, it can cause hot flashes and night sweats, and too much can cause hot flashes and night sweats. So that's why we test. And then let's say we have someone whose estradiol level looks good on a test. Then it could also be that if estradiol is supposed to be here and progesterone is supposed to be here, and someone has a good estradiol level, sometimes the reason they have hot flashes is because their progesterone is low. So they've created an estrogen dominance. You see how my estradiol is higher than my progesterone? According to my natural design, they should be balanced. But if I have good estrogen, but my progesterone level is low, then for some women, we can correct their hot flashes and night sweats with just progesterone. Now, if somebody has low progesterone and low estrogen, then we have to replace both. And then if we have somebody who has too much estrogen, then we have to get them to poop, fix their liver, use the supplements we have to get their estrogen level to come down.
Excuse me.
There must be some allergen in the air that you and I are dealing with.
Mhm.
All right. Hopefully that was clear on hot flashes and night sweats being related to varying amounts of imbalanced estrogen and progesterone. So again, if you're seeing a regular doctor or provider and all they're giving you is estradiol and they're not testing, or they're giving you estradiol and progesterone and they're not testing, they don't know where your levels are, if they're balanced, if it, they could have given you some and it could have ended up like this and you're still having hot flashes. It could be, oh, well, do we need to raise the estrogen or the progesterone? Testing helps you determine which one needs to be tweaked.
Okay. Let's talk about mood swings and anxiety, because that is common among women going through perimenopause. And I think it's important to know that that is definitely, it's related to the changes, right? These are from hormone imbalances. And, the first thing, we don't want you gravitating right to what medications we can take. Let's look at the hormones first. What can we do about that, Dr. Saxena, how we can try to help regulate their moods better?
Great. I really want to reiterate what you just said, Jocelyn, because it's worth repeating. Many women have been told, especially if they're in their 40s, that when they become irritable or sad or unmotivated, that it is a mental health problem and therefore will be placed on what's called an SSRI. You might know these things as Zoloft or Lexapro or Celexa or whatever is the, antidepressant, anti-anxiety medicine. Now, I don't want you to think that there's no value in that. But what I'm saying is that there was a study done in Cambridge, which is the very well-respected university in Great Britain. And I'm going to ask to see if you guys wouldn't mind being a little interactive with me in the chat. What do you think is the 4 to 5 year period where women are most likely to be suicidal. Go ahead and just give a guess in the chat if you're willing to play the game. I'm going to give the answer for sure, but when are women most likely to be suicidal? Great. You guys are smart. You know that I'm playing into this subject matter. It's actually 45 to 49. Good job, Sneha. Good job, Shruti. So it is during the drop of progesterone and estrogen when women are most likely to have symptoms that will then be called anxiety, depression, and then they get placed on an SSRI when they could have done a root cause analysis. And if their progesterone and estrogen were low, they could replace those. And we will see often, oh, well, now they're sleeping. Their estradiol, remember, is Barbra Streisand. Like when we lack our Barbra Streisand hormone, we get kind of, you know, we're not happy. We're moody. And let me tell you, what's another time in a reproductive woman's cycle that she has low estrogen and low progesterone? PMS. When you look at a 28-day cycle, the 7 days before you get your period is when you have low progesterone and low estrogen. There's some women who are happy during that time, but there's many of us who get a little moody, a little irritable, a little sensitive, a little, if I may say, bitchy. And that's because of a lack of estrogen and progesterone. Well, that is a daily thing starting in perimenopause. Y'all get that? And you can just imagine how that's compounded day after day after day. You're not sleeping well. You don't have Barbara there to, you know, kind of make you feel juicy and alive. And then the other thing that Barbara does is she makes our brain work. So in perimenopause, menopause, you can see up to, studies show, an up to 30% decline in your brain function, in your thinking abilities. So if that's true, can you imagine not sleeping well, not having a zest because your Barbara levels are dropping, and then your brain's not working? Like to be able to be productive at work or at home or whatever you need to be doing. You can see how that is like a little stewing problem there that can then increase a woman's risk for what looks like a mental health issue. So just remember that this is widely under-recognized as the source of depression, anxiety. Don't underestimate the benefits of replacing hormones to be able to help with mood swings and lack of motivation, brain fog. And just because I think that because nobody's ever simple, estrogen dominance, meaning having too much estrogen, can also make you feel a little irritable. So again, if you replace hormones and you're not feeling better and you're feeling worse, it could be that you had estrogen dominance going on. Oh, Jocelyn, I think you're muted.
Sorry about that. So with the lack of Barbara in our lives, we know that it's affecting our cognitive ability, just our brain, you know, how our memory, how word recall that we all kind of get stuck in, right? Just trying to remember that word when we're in conversation with someone, putting a name to that face, all of those issues, right, can all be, could be helped with Barbara. And how can we help fix Barbara? And not just for things like fatigue or to help improve energy and brain fog. What about for vaginal too, for vaginal health? Because women do complain about atrophy in menopause.
Yes. So there are many different departments that Barbara, which is our code word for estradiol, Barbra Streisand. Okay. She kind of makes sure that everybody's happy and sparkly. Okay. One of the places she makes happy and sparkly is the vagina. And to have a happy, sparkly vagina, it needs to have proper moisture. So if there's not enough Barbara down in the vagina is dull and dry. And when it's dull and dry, we call that vaginal atrophy. It means that the cells are kind of getting dry and old. And that means they're vulnerable to damage. So you can imagine how much fun sex would be having a dry, dull vagina. It's probably painful. It's uncomfortable for some. It's damaging for some. So it's important to know that that is one of the early signs of perimenopause and a common sign of menopause. And if you have a reason for why you can't take estradiol for the whole body, it is very safe to take local estradiol therapy in the vagina as a cream. And one of the things that functional medicine providers do is they use vaginal estriol. So that's estriol. Now, Jocelyn mentioned there's actually three, I call them three sisters, the three estrogen sisters, okay? The first one is called estrone. She's the big sister. She's the one who's kind of going to be the sacrificial lamb for the happiness of the other ones. And she can kind of be a good sister, but she can also be kind of a problem sister, okay? That's estrone. Number two, the middle one is Barbara, estradiol. So E2 is estradiol. And she's the one we've talked about. Passion, drama in a good way, creative. She's strong and dominant. And then E3 is estriol. And she's kind of like the little bookworm sister. She's there to help, but she's not super powerful, but she's really useful at times. And so E3, or vaginal estriol, is very effective as a cream for vaginal dryness or vaginal atrophy. And there's a very safe protocol that you can find, which will basically stimulate that tissue to start producing mucus, appropriate mucus again, so the tissue is healthy. And that is also super useful for women with bladder issues. So I don't know about you, Jocelyn, but for me, there's women, when they get dry, they're really prone to getting UTIs again. They're prone to having prolapse. You know, like let's say you just had a less than pretty vaginal delivery that kind of, really changed up some of your anatomy down there on the way out when the baby was coming out. Well, when the tissue gets dry and thin, then the bladder or the colon can start to kind of prolapse or kind of balloon into the vaginal canal. And then when things start ballooning in and moving out of position in your pelvis, that can lead to bladder infections, constipation, pain, things like that. Anything to add there, Jocelyn, for you on that?
No, other than there, if you're looking to, if women are curious about other things that we can do for dryness too, there's also DHEA. I know, Dr. Saxena, you like to use that, and you put the capsules in the vagina, correct? At nighttime, and that helps. So that's something new I've learned from you. Of course, we're always looking for natural products. So there's many synthetic products over the counter that you have to really be careful of. And there's companies out there that can compound, and we actually use compounding products too, that we can put a few things in there. It doesn't just have to be strictly estriol. So there's options.
And listen, I was trained by an amazing OBGYN. I'm a family practice OB certified, so I can do low risk delivery. So I saw my fair share of women's health issues when I was in my younger years as well too, in training. So all that to say, if you're like, I don't want any hormones, I'm anti-hormones, I get it. What you could do is use coconut oil or olive oil, EVOO. Maybe have your own stash for the vagina. Keep it separate from what you use on the stove. I think everybody would be happy about that. So that's something you can start with. Now, that is not going to bring back your estrogen. It's not going to bring back your vaginal tissue, but at least it serves as a surface lubricant. And coconut oil has some antimicrobial properties. It's anti-yeast, anti-bug. So, it has some benefits. So if you're like, I really don't want to rush to estrogen right off the bat, even though it's so safe, it will not be absorbed into your system, you could try coconut oil or olive oil.
Great. So I know we have mentioned about bioidentical hormone replacement therapy. And in our next session, in 2 weeks, we're going to really delve deep into that. But in the meantime, we want you to know Dr. Saxena is going to give you some other options of how to improve your lifestyle that can better manage your symptoms other than BHRT.
Yeah, we're going to go into that. We have a whole session because there's no rule that says you pick hormones or lifestyle. We always assume you're going to try to optimize lifestyle as much as possible. But I'll just tell you as a closing remark, there are some people who really need the benefit of the hormones to even have the cognition to take on a healthier diet, or they need the energy to take on exercise, or they need the progesterone to just get over the poor sleep cycle that they've gotten. So I never want you to think that we say, oh, hormones and forget lifestyle. It's your easy, pass out of doing anything with lifestyle. That's so not true. Our goal is to leverage as much lifestyle as possible. So we use the lowest amount of hormone replacement that is necessary. And for people who cannot or do not want to use hormones, then we just will be even more personalized and strategic with lifestyle. So we'll talk about that at a future webinar.
Okay, great. It's 1:28 right now, so I know many of you have already posted questions here, and we only have a couple of minutes to address them. So what I would like you to do is just take it, copy and paste it, put it in the WhatsApp, and then we will answer them individually. So you're getting the time to get a full answer, okay? Not something that has to be rushed. So I will just go back because I know we did talk a little bit about the vitamin D, and someone did ask, let's see here, vitamin D 25OH is a lab to ask for, correct. Also, Usha is asking if we're already taking multivitamin for 50 plus, do we take an additional D3 plus K2 supplement? So, not all multivitamins are created equal. I will start with that, and then Dr. Saxena will answer.
Yes, that's right. So whenever we get a provider who's been in the conventional world and then comes over to the functional and starts doing testing, they'll see how much, there is a lack of certain nutrients. So most multivitamins do not have enough D3 with K2. Now, I find that the standard dose for D3 with K2 that many women need is 5,000 IUs a day with 90 to 180 micrograms of K2 a day. And some people are under the impression that 1,000 or 2,000 is enough. Again, it might get you to 30. And again, if all you want to do is stop rickets, that's good. But you need, in our opinion, to get up to 50 to 60, and therefore 5,000 is what most women need. And then some women need to even do a short stint of 10,000 international units of vitamin D3 for 3 to 4 months just to get their level up. And then they can drop down to the 5,000 to remain at the right level. So the other thing I'm going to say as a last tip is you do not get credit for what you swallow as a supplement. I don't care what the label says. You don't get credit for that. You get credit for if that supplement is good enough to be broken down in your digestive system and be absorbed. So if you look at the label and assume that you're getting 100% of that, then that's a little bit of a faulty assumption because your gut cannot absorb all of what's in that capsule or tablet. And the cheaper the supplement, the more likely you have expensive poop. Okay, good. Shelley got my joke.
That's a great.
Okay.
That's a great way to end the session. At least one thinking.
Yes. Who wants expensive poop? You want stuff to get into your bloodstream, and that means better quality supplements that can break down. So whatever's in the supplement actually makes it into your body. Okay. On that
Excellent.
little tip, we probably can close out this session.
Very much. So we'll see you in 2 weeks, and please review on the WhatsApp. Our gentlemen over at Longevity Labs are doing a great job. They're putting, they're taking the highlights of our previous sessions and little short clips, video clips that you can take a look at, as well as some Q&A that are very common answers. So please take a look at that. And let me reiterate again for all that did post on the chat, please just take that, copy and paste it into the WhatsApp, and we'll definitely address that to you today before the end of the day. Thank you.
Thank you all.
Bye, everybody.
Bye.